Again, no disclosures. And the objectives of the talk today are to be able, I hope by the end of it, you'll be able to describe some of the core mood symptoms of PMDD, to be able to name some risk factors for postpartum depression, and to be able to describe some affective symptoms that can occur around perimenopause. So I'll be talking at first just really briefly about what is reproductive mental health, and then getting into the main kind of reproductive affective disorders, which are PMDD, postpartum depression, and perimenopausal depression. And then I'll come back and focus more on PMDD specifically, going into a little bit of the biology. So reproductive mental health, what is it? You may have heard other terms like reproductive psychiatry, reproductive psychology, reproductive health psychology, or even women's mental health. The reproductive refers to reproductive hormones, so ovarian steroid hormones. And this was an article from a couple of weeks ago in the New York Times, and it's titled, "Sex Hormones Are Brain Hormones." And so sex steroid hormones like estradiol and progesterone can have really profound effects on the brain. And so we think of these reproductive affective disorders or reproductive mood disorders as disorders of hormone sensitivity. So before we get into that, I'm going to step back a little bit and talk big picture about sex differences, just to put it into context a little bit, and then we'll go into the sort of sex-specific diagnoses. So if you notice on this chart, you'll see that rates of anxiety disorders and major depression in women really dwarf the levels in men. And you can see for men, they tend to have higher rates of impulse control disorders and substance abuse disorders. And so these sex differences start to emerge around puberty. So during childhood, boys and girls actually have fairly similar rates of depression and anxiety. Once you hit puberty, you start to see differences where girls start to have higher rates of depression and anxiety disorders. This persists through adulthood. We'll talk about the perinatal timeframe as well as a sort of time of risk for mood symptoms. And these differences persist up through menopause, when then things kind of level back out again. And so this is data from a recent study published in Lancet Regional Health. And this was from one of those really nice Swedish patient data registries. And it looked at actual diagnosed depression, diagnosed anxiety disorders. And they found that when you look at the rates of depressive disorders, you can see in females in red, their rates are much higher. And in particular, you notice that those rates start to really spike right around puberty. You see in that like around 12-ish age range, that massive increase in rates of depression in girls, and then they start to come down, and then you notice around like 50-ish, early 50s, they start to kind of converge again with the rates in males. That's a similar pattern for anxiety disorders. So again, they start to diverge around puberty and then converge again around the time of menopause. So then moving away from sex differences and getting into these sex-specific disorders. So across the female lifespan, we see points of increased risk for psychiatric symptoms. And so these include the menstrual cycle, where you'll see PMDD, like we just heard about. Around pregnancy and postpartum, you can see postpartum depression. And then around the time of menopause, you can see perimenopausal depression. And so these reproductive affective disorders are sex-specific, and they are ovarian hormone-mediated. So first, I'll give just a brief overview of PMDD before kind of coming back to it in more detail. So PMDD, it is an affective disorder. It has a cyclic pattern, and symptoms emerge in the luteal phase of the menstrual cycle and then remit in the follicular phase. And so the symptoms are turning on and turning off with the hormone fluctuations across the menstrual cycle. The two main phases of the menstrual cycle are the follicular phase and the luteal phase. You can see over here, the follicular phase starts with menses, so the menstrual period starts, and hormone levels are pretty stable. Then ovulation, this kind of marks the midway point of the cycle, and then from ovulation until the next menstrual period, that's the luteal phase. And you can see in the luteal phase, there are things are more dynamic hormonally. The estradiol and progesterone are fluctuating, and you can see particularly progesterone, there's quite a rapid drop-off. So PMDD's core mood symptoms, you have to have at least one of these symptoms in order to be diagnosed with it. So you can see affective lability, so this can look like tearfulness or more sensitivity. Irritability, this can look like anger or interpersonal conflict. Low mood, you might see hopelessness or kind of negative self-deprecating thoughts. Or anxiety, this can look like tension or worrying. These are just some clips from an article that came out a few years ago that was capturing the subjective experience of women with PMDD. And you can see it's not just sort of major depression that's turning on and off with the menstrual cycle. It's a little bit more subtle than that. So you can see in the first quote, the person is saying, I feel like this is an alter ego. And I hear that from my patients as well, that during that premenstrual week, they feel like a different person. The second quote, you can see she's mentioning, I felt really low, I felt hopeless, tearful, but also angry. So there's that irritability component. And then the final quote, you can see she's saying, it was depressing, I was miserable, and also the anxiety component. So again, I'm going to come back to PMDD, but we'll move on to postpartum depression. So brief overview. It's simply a major depressive episode with onset within the first month postpartum, and this occurs in 10 to 13% of deliveries. Some risk factors for PPD, previous postpartum depression, if you'd had a previous delivery and experienced it then, depression or anxiety during pregnancy, and past history of depression or anxiety. So if you had depression or anxiety outside of the context of pregnancy or postpartum. And then contributors, they include social isolation or poor support, role change. So, especially for first-time parents, going from being a non-parent to a parent can be quite an adjustment. And so that change in role can be stressful. Relatedly, there can be changes in the relationship between the partners or spouse. Sleep deprivation, that's another big one that can really have an impact on mood. And then infant temperament, so if the infant is really fussy or difficult, that can be stressful as well. And so postpartum is characterized by this really rapid drop-off in hormones. So you can see over the course of pregnancy, the hormone levels are kind of gradually ramping up. And then at delivery, they have this massive decline very quickly. And so just to kind of illustrate, how quickly these hormone levels are changing. And we think in postpartum depression, again, what may be going on is this sort of sensitivity to that rapid drop in hormones. An interesting recent development in postpartum depression treatment is this medication brexanolone, which is an IV formulation of allopregnanolone. And this was a clinical trial done a number of years ago. When I was at UPenn as a postdoc, we were one of the sites for this brexanolone trial. So it's an IV infusion, and it had a really nice response rate. And so you can see that in the patients with postpartum depression in orange who got the active medication, they had a pretty rapid improvement in their depressive symptoms, and then they maintained that up through a month post-treatment. And then I'll touch again briefly on perimenopausal depression. So the menopause transition is characterized by kind of erratic hormone fluctuations. So you can see in that perimenopause phase, this is the years leading up to the final menstrual period, and it can be 4 to 10 years. It can be a pretty prolonged period. And so menstrual cycles will be very irregular, and you can see the hormones are fluctuating even kind of outside of the range that they would kind of normally remain in. And then you can see so menopause is when you've had the final menstrual period, and that's when the hormone levels are kind of low and stable. Again, just like with postpartum depression, yes, you have this massive hormone shift, but you also have these psychosocial factors happening. And so this chart, I think, really nicely illustrates that. So yes, there are neuroendocrine changes, but there can also be changes in relationship status, health-related issues, things like that. There have been a number of really nice longitudinal studies in the US that have followed women from premenopause and then across the menopause transition. These are the 4 major ones, and they actually all showed increased incidence of not just major depressive disorder itself during perimenopause, but also subsyndromal depressive symptoms. This is data from the Penn Ovarian Aging Study, again, done at UPenn, and you can see that as you kind of move through that menopause transition, the rates of depression, so this is based on CSD score and sort of using the 16 or more cutoff as being suggestive of major depression. And so you can see that that's increasing across the transition, and then once you get into postmenopause, it drops again. Interestingly, again, kind of getting into the hormones, and this could be its own talk, but just to give a little taste of it, this was really nice work done by Peter Schmidt at NIH in their Behavioral Endocrinology Division. Dr. Schmidt is a real leader both in PMDD and also perimenopausal depression, and he does these really beautiful studies where he will administer hormone and then withdraw it and kind of see how that affects symptoms. And so in this study, he brought in women who were postmenopausal, but they had a history of perimenopausal depression. And for some of them, he gave them estradiol, and they just stayed on estradiol. You can see that the blue line with a triangle sort of towards the bottom. And so they were on estradiol, they were doing fine, their mood was fine. For some of them, after 3 weeks on estradiol, he took them off and switched them to placebo. And you can see, as soon as they go into placebo, their depressive symptoms really skyrocket. So again, suggesting this idea of hormone sensitivity. All right, so I'm gonna shift gears and again, go into a little bit more detail about PMDD. So PMDD is the most severe form of premenstrual mood symptoms. So they do occur on a spectrum. They're actually relatively common. So this was data from the Flow app. So I had the opportunity to work with Flow, which is a menstrual cycle tracking app. And we're able to look at data from, I think it was like 120 countries and over 200,000 participants. And we found that mood symptoms were the second most commonly reported symptom behind only food cravings. So, premenstrual mood symptoms themselves are pretty common. Again, it's that subset of people who have PMDD that's kind of at the most severe end of the spectrum. So PMDD prevalence is around 2 to 8%. And to put that into context, if we pop PMDD up here, you can see that it is about similar to rates of in women panic disorder or OCD. That translates to affecting around 31 million people worldwide. And when you look at just the raw numbers, PMDD actually affects more people per year than postpartum depression, which is an interesting tidbit. PMDD is also quite under-recognized. So I've co-authored a couple of papers looking at some of the barriers to diagnosis and care in people with PMDD. So I'm going to talk a bit more about this hormone sensitivity hypothesis, specifically in PMDD. This is the idea that there's altered central nervous system sensitivity to normal hormone fluctuations. One of the key players that I'll talk about is allopregnanolone, and this is a neuroactive steroid. It's derived from progesterone, and this is a hormone that is of interest in PMDD particularly. So neuroactive steroid hormones are just steroid hormones that interact with the central nervous system. So they include things like progesterone, allopregnanolone, estradiol. And allopregnanolone specifically is an allosteric modulator of the GABA-A receptor. So it potentiates the GABA-A receptor function. So that means it has anxiolytic and sedative effects. When we think about PMDD, one of the initial questions was, well, do people with PMDD have a difference in just the levels of hormones like progesterone or allopregnanolone? It turns out they don't. So there have been a number of studies that have found that at a single time point, you don't see differences in levels. This is data from my K23. This was serum allopregnanolone. We had people with PMDD and without PMDD, and their allo levels were the same in the luteal phase. What we do see, and this is a really nice study that came out a number of years ago, it was looking at progesterone, not allopregnanolone, but it was following it across the cycle, and it was looking at salivary levels. And so you can see in the bottom panel, these are people who are asymptomatic. So they were controls, and you can see the little white dots, those are their salivary progesterone levels. And you can see it's a nice, just kind of slow, gradual decline. The upper panel, on the other hand, those are people with PMS. PMS is a sort of milder syndrome than PMDD, but does involve some mood symptoms. And you can see they have this kind of interesting, kind of more sharp decline in progesterone levels, especially in those like 3 days before menses. There is also evidence of alterations in GABA-A receptor function in PMDD. So this first study is from a really great group in Sweden who does really amazing research in PMDD. And they found that, so normally if you give allopregnanolone, just like a bolus injection of it, it'll have sedating effects. They found that when they gave it to people with PMDD, it did not have these sedating effects, at least as measured by this saccadic eye velocity, which is an index of GABA-A receptor function. In my K23, I tried to do a bit of a replication. So I used something called anxiety potentiated startle, which is, again, a similar kind of proxy marker for GABA-A receptor sensitivity. And we found that in people with PMDD, so we have controls in the dark gray, and you can see that their acoustic startle levels are stable across the menstrual cycle, so from follicular to luteal. And then in a second luteal phase, controls did not get SSRI, but people with PMDD got low-dose sertraline. You can see they stay level, but the people with PMDD in the gray, the light gray, you can see that in the luteal phase, their startle increases, and then when we gave them SSRI, it actually brought it back down to be even lower than the controls. So again, suggesting there may be something going on with GABA-A receptor function. And this was published a few years ago. So kind of putting these things together, it looks like there may be differences between people with PMDD controls in terms of both the allo fluctuations across the luteal phase, as well as the sensitivity to those fluctuations. So next steps to follow up on this was an R21 that I just wrapped up. And so we wanted to look at neuroactive steroid levels across the luteal phase in PMDD versus controls. So we got blood every other day across the week before menses. We also looked at GABA-A receptor subunit expression in blood cells. And we actually just got the raw data back like last week. So we haven't looked at it yet, but I'm really excited to see what we find. And then I want to touch briefly on SSRIs for PMDD, which we heard a little bit about. So they have a couple of interesting features. As we heard, they tend to work very rapidly in PMDD. So instead of, the weeks that it can take to take effect in major depression, they can work within 24 to 48 hours in PMDD. And they can also work at relatively low dosages. And so we think that this may be because they're working through a non-serotonergic mechanism in PMDD, that they're acting as what has been termed selective brain steroidogenic stimulants. And so the idea is they may be affecting this enzyme 3-alpha HSD that mediates the conversion of progesterone to allopregnanolone. And this is just showing that pathway. So we think that the SSRIs are kind of pushing that towards allopregnanolone. And there's been some really nice work on this by my collaborator, Graziano Pinna at University of Illinois, Chicago, who has been publishing for a number of years about this idea of SBSSs. Some of his work shows in major depression that SSRIs do in fact enhance allo production. So these were serum levels of aloe in people with major depression who were treated with fluoxetine. They've also found similar things when they look at CSF in major depression. But there had not been great studies on this in PMDD. There had been one study in PMS, which again is milder. So for my K23, we wanted to look at, are SSRIs actually enhancing aloe production in PMDD? And so interestingly, we found that aloe levels were not increased significantly by the low-dose sertraline. We did see that levels of pregnenolone were trending towards being increased by SSRI treatment in the luteal phase. And then what we did see, interestingly, was that the ratio of pregnenolone to progesterone was increasing, and that was significant. And so again, if we go back to this pathway, it's this idea that, if the ratio is changing, so we're seeing higher pregnenolone, lower progesterone, it suggests that it's pushing the reaction closer to pregnenolone. Pregnenolone is similar to allopregnanolone. It also acts on the GABA-A receptor. And so even though aloe itself wasn't increasing, its friend pregnenolone was. And so again, this is sort of indirect evidence that sertraline could have been increasing the neurosteroidogenic enzyme activity, although it was not placebo-controlled, so we couldn't tell for sure. So next steps. So as Dr. Potash mentioned, I'm just starting up an R01, and it'll be looking at placebo versus low-dose sertraline in the luteal phase. So again, adding that placebo control so we can really see, what is SSRI doing versus placebo in terms of neuroactive steroid function. We'll be measuring every other day neuroactive steroid levels, GABA-A receptor subunit expression, as well as those enzymes I mentioned, so 3-alpha-HSD as well as 5-alpha reductase. And then a couple of other kind of upcoming projects, things that I'm working on. I have, again, these two R01s looking at some of these biological underpinnings of PMDD, and then a Catalyst Award looking at some of the more kind of like health-related aspects of PMDD, so looking at markers of inflammation, and a SCORE grant, again, to look at microbiome in PMDD. And with that, I would like to wrap up. So I'd like to thank my team, so all of my collaborators, colleagues, mentors, my students and mentees, the research coordinators who, none of this would happen without them. They are fantastic. And of course, the research participants. And again, with people with PMDD, we're bringing them into the lab when they're in the luteal phase. They're not feeling great, and we're stressing them out and drawing their blood. So I really appreciate their participation. My funding sources, and then there's a QR code if you're interested in looking at some of my current studies they're recruiting. And that's it.
Thank you, Dr. Hansen. That was really interesting. We've lots of time for questions, which is good because I have lots of questions. I imagine other people do too. Let me start with this. Of course, the idea that low-dose sertraline is effective is so intriguing. Are there times when you have to make a decision about whether to use low dose or high dose? I'm trying to think of whether, if you use high dose, I don't suppose you lose any of the benefits that would accrue from low dose.
No, yeah, and I've seen both. So the psychiatrists that I work with and have worked with in the past, they often for PMDD will start with a low dose. Often I'll see that when people have kind of a time limited, like if they're only having premenstrual symptoms in the few days before menses, they might start with a lower dose. But I have seen higher doses as well. And like you said, it's not that you lose benefit by using the higher dose.
Right.
I think for some cases it can be a question of side effects as well.
Yeah.
So,
yeah. Right. Well, I have lots of other things on my mind, but I imagine other people have plenty of things on their mind too. Dr. Gilbert.
Great.
always remembered to repeat questions. I should repeat the question. For brexanolone, does it matter whether a person has a prior history of MDD or not?
Yeah, so the sort of like cleanest cases tend to be people who it's this sort of really pure postpartum depression that tends to respond really well to brexanolone. And so that is, the sort of first episode depression, and it's occurring pretty immediately postpartum. Again, that tells us that it's this probably sort of hormonally or biologically driven postpartum depression. And some people think that there might be even these sort of subtypes of postpartum depression, some that is very kind of strictly hormonally mediated, and then others that might be more like classic major depression, where it's, stress triggers it. And again, like I mentioned, postpartum, there can be sleep disruptions, there's stress of dealing with a baby. And so kind of disentangling that can be tricky. And so I know that they've tended to see the kind of cleanest results in people who don't necessarily have a past history of depression, and that the onset of the postpartum depression is, pretty shortly after delivery.
Great, thanks. Other folks? Well, I will ask. Our patient raised this issue of people who have less severe symptoms. And I presume the FDA indication for using sertraline is meeting the criteria for premenstrual dysphoric disorder. But does it ever make sense to treat people who are sub-threshold?
Yeah, for sure. So it's a pretty high bar to meet diagnostic criteria for PMDD. And I didn't even go into this part, but in order to diagnose PMDD, the sort of by the book way is that the person has to do 2 months of daily mood rating. So 2 menstrual cycles every single day, they have to rate their mood. And so that's quite an intensive process for the patient, as well as for the provider then to kind of work through those ratings and look at the patterns. So it is a high bar to be diagnosed with PMDD, and the symptoms have to be relatively severe. Like I mentioned, there is something called PMS, which is a milder syndrome. And it's this really interesting kind of divide between, so PMDD is defined by the APA, and it's in the DSM. PMS is defined by ACOG, the American College of Obstetrics and Gynecology. And so for PMS, you can actually, you're not required to have mood symptoms to be diagnosed. You can just have physical symptoms, whereas PMDD, you have to have the mood symptoms. But yeah, there have been trials for people who have PMS with mood symptoms. Sometimes people will call it MPMS to indicate that they're mood symptoms. And so, yes, that is also responsive to the low-dose SSRI treatment as well. Yeah.
The data is pretty good that it does respond.
Yeah, there have been a number of studies looking at people with just PMS. Mm-hmm.
That's interesting. Other thoughts, other questions? Go ahead. Dr. Schreier. Thank you, Dr. Schreier. Go ahead. Interesting question. How many women may not realize that there's anything they should be seeking attention for here?
Yeah, absolutely. Yeah. So I've done a little bit of work in this area, and there are barriers to diagnosis. A is just realizing that this might be happening and finding a provider who's familiar with it, and then B, once you doing those 2 cycles worth of the daily ratings. And so, there are definitely people who have come to me both clinically and also research-wise who will say either like, oh, yeah, I just thought this was normal, and they'll be like sort of shocked that there are people that don't experience premenstrual mood symptoms. They just kind of assume like, well, I guess this happens to everyone, and I guess this is normal. And for some of them, it's it was really interesting for my K23. There were some people who would come in for the screening, and they would see a flyer that says like, oh, like, do you have like PMS or premenstrual mood symptoms? And they would come in and do the screening, and they would be like, this is the first time I really kind of tied this stuff to my cycle. Like, they knew that they had mood symptoms kind of, intermittently, and they hadn't necessarily tied it to their cycle. Once they did, then it was very clear, like, oh yeah, it's following this pattern. Relatedly, it also gets misdiagnosed quite a bit, so it's often misdiagnosed as bipolar disorder. So again, that's a cyclic disorder, and sometimes people will see, well, look, the symptoms are turning on and off, so like it must be bipolar disorder. But of course, the treatments for bipolar disorder versus PMDD are very different, and so that can be a challenge as well. Yeah.
Interesting. Dr. Redgrave.
Thanks, Lisa. That was great. I guess it's sort of in line with other questions. Is there any thought that would you consider doing a treatment trial for either women with bipolar disorder that appear to have perturbations related to their cycle, or women with major depression with perimenstrual worsening? Because some folks have irregular cycles, but they have side effects with higher doses of medicine, et cetera.
Would you consider trials in people with women with bipolar disorder or with major depression who have these symptoms?
Yeah, so premenstrual exacerbation was the one sort of reproductive affective disorder that I didn't talk about. And so there are, for any given disorder, many women will experience worsening of it premenstrually. So around 60% of women with major depression will experience premenstrual worsening of their symptoms. And again, you can see the same thing with, I don't know the actual rates in bipolar disorder, but you can see in bipolar disorder, GAD, you name a disorder, some proportion of women will have premenstrual worsening of it. A couple of things that I've seen my colleagues do for premenstrural exacerbation is to increase the dose. So if they're on a specific dose of an SSRI, the psychiatrist will then bump it up in that premenstrual week. But there's not a ton of research on premenstrual exacerbation, I think because it's very, it's difficult to study because you're dealing not only with, say, major depression, but then you have to capture that premenstrual component as well. And you also have to, again, this sort of difficult differential diagnosis that can happen, you have to make sure that it's major depression with premenstrual exacerbation and not PMDD. And so sometimes it can be hard to differentiate those two as well.
Great. Thank you. I don't think too many of us have experience with zuranolone. Our patient had described some pretty marked side effects. Is it a medication that, well, actually, I don't have much of a sense of how widely it's been used at this point, but is there much experience with side effects?
Yeah, so with zuranolone, which is the oral form of brexanolone, so they're both basically allopregnanolone. One is an IV formulation, one is a pill form. Sedation is the main side effect. And, like I mentioned, since allo is affecting the GABA-A receptor, it has these sedative qualities. And so when you give allo as, as an IV or as a pill, it can have these sedating effects. And that's one of the main side effects. Typically when it's being prescribed for postpartum depression, they'll recommend that the patient have someone else to help with caregiving for the baby. They'll recommend not driving, and there's kind of similar warnings like if if you're taking sort of sedating medication or alcohol, and it's well, don't drive, don't operate heavy machinery. It's similar sort of qualifications for brexanolone because of those sedating side effects.
Okay. Yeah. Thanks. Other folks? Yes, Dr. Weiss.
Yeah, So that's another thing that people do. So it's, oh, and sorry, the question was about sort of shorter, like monthly courses of SSRIs. That is another sort of treatment regimen that people will use. So it's called intermittent dosing or luteal phase dosing, and it's basically just taking the SSRI during that luteal phase. For some people, they'll take it from ovulation until their period starts. For other people, again, if they have this really kind of constricted time frame where they're only having symptoms for a few days, then they might, they do what's called symptom onset dosing, where they just start taking it, 3 or 4 days before their period is kind of like when they first start seeing the hints of symptoms starting to emerge. So yeah, that's another way that SSRIs can be used in PMDD.
Go ahead, Dr. Olson. Is getting zuranolone ordered and prescribed easier than brexanolone?
Yeah, so again, I'm a psychologist and not a psychiatrist, so I can't speak to it with direct experience, but from what I've heard from my psychiatrist colleagues, like it is a challenging process. What do you say, Jamie? Yeah.
They're quite motivated to getting it is quite challenging, but there is a rep that's linked to our area that is motivated to move you through the process, but it's quite time consuming. So in a busy practice, like you need your ancillary staff to stay on top of it. And there's 2 patient calls where they have to like confirm their insurance. They have to get a hold of them twice before they ship it out. And it's only at it would be mailed directly to their house. They can't pick it up at a commercial pharmacy.
Interesting. Other questions? Dr. Gilbert. Are there any mother-baby intensive outpatient programs designed on the East Coast?
Yeah, so I believe UNC, University of North Carolina, has one. As far as I know, that is the only one. Is there one at Mass General? Oh, Georgetown. Okay, awesome. Cool.
Wow, in D.C., huh? Interesting. Okay, if no more questions, I will thank Dr. Hunt for a great turnout.